Operating room setup for shoulder arthroscopy can be a complex task requiring several people doing different jobs with a lot of different equipment. We at SCOE hope you may find all or part of this video helpful in your operating room. The operating table is placed in the center of the room with several items on it: towels and/or support for the head, a beanbag to support the patient in the lateral position. The post-operative dressing, which is a non-adherent dressing, can be put on before the patient gets on the bed. To facilitate patient mobilization, we place a draw sheet over the top of the deflated beanbag, extending from the top of the shoulders to below the hips, 4 pillows to support the knees when the patient is in the lateral position, and DVT prophylactic devices to go around the legs. The arthroscopic boom is set on the contralateral side of the table as the surgical site. The traction boom is an essential part of the arthroscopic shoulder procedure and should be set up appropriately. It is attached to the distalmost bar of the operative table. It is set up such that the crossbar is placed nearly all the way up on the central pole, securely tightened to prevent any rotation. There is a yellow cable and a white cable. Those are the only two we use. The third red cable, which is used for distraction of the shoulder, is rarely required. There are 2 buckets for catching outflow and a step stool that is often used when tying suture knots at the end of the case. We prefer a foot control for the power shaver in the vast majority of our arthroscopic shoulder procedures. The tower is placed on the contralateral side of the table and holds the monitor, light source, camera, pump control unit, printer, and media recorder. Some SCOE arthroscopy towers are also equipped with a second monitor for viewing exterior shots. The basic instruments of an arthroscopic setup are assembled on 2 Mayo stands and 1 table. This Mayo holds the remote control for the pump, the shaver, suction tubing, the arthroscope, and its light cord. The long table holds the pump tubing, gowns, towels, and all the various instruments and devices used for the specific procedure. The second Mayo stand holds the patient's drapes, additional towels for the suspended arm instrument holder, and basic instruments including a grasper, a loopy grasper, switching sticks, outflow tubing, a probe, a basic cannula, and sharps in a metal kidney basin for protection. The post-operative dressing is secured over the patient's thorax. An operative team on either side of the operating table carefully rolls the patient into the lateral decubitus position with the gel axillary roll placed approximately 2 finger breadths below the axillary fold. The patient's thorax is stabilized with the beanbag positioned just below the inferior edge of the scapula, with the patient's shoulder leaned posteriorly approximately 20 degrees. The beanbag edge is positioned out of the patient's downside axilla and is held to prevent movement while the beanbag is insufflated. The patient's hips should be tilted slightly posterior, approximately 5 degrees, to prevent forward leaning. The beanbag is firmed up against the patient and the postoperative dressing tucked out of the way, so it is readily available at the end of the procedure. The head is covered with a towel. The star sleeve is applied to the operative arm, evenly distributing compression. The arm is suspended from the boom with 10 pounds of weight in approximately 60 to 70 degrees of abduction and 15 degrees forward flexion. Waterproof drapes are adhered to the towel and neck area with care taken to avoid the ET tube. Starting from the top, a watertight seal is created, with special attention anteriorly where water may likely leak through. The drape is then sealed moving posterior, just below the level of the beanbag. A 10-10 drape is placed distally, well below the axilla, allowing room for prepping and final draping. Prepping is now done following standard protocol. A second drape is placed in sterile fashion over the patient. This is followed with an adhesive split drape that is properly positioned with the paper heading up. The top is placed posteriorly, adhering to the skin, and then brought anteriorly and secured, minimizing the unsterile space that is covered with a sterile 10-10. The final drape is secured, taking care to avoid the unsterile arm. Non-sterile Coban is wrapped with a thick sterile towel, which is in turn wrapped with 6-inch Coban to create a bandana-type holder for frequently used instruments such as graspers and switching sticks. The Mayo stand with the shaver, pump control, and arthroscope is covered with a towel and carefully moved in a sterile manner, positioned to the anterior aspect of the patient, between the operating table and the arthroscopic tower. The bundle of section, shaver, pump, and scope tubing and cables are sequentially passed off to the circulating nurse, and a non-penetrating Kelly clamp is used to secure the drape around the bundle of cords at the patient's upper thigh hip area. The scrub tech removes the protective towel from the anterior mayo, and the circulating nurse safely connects the cords to the tower and water supply. The gravity tubes are attached to the runoff bag and directed to the collection bucket placed at the head of the table near the anesthesiologist, where the quantity of drain fluid can be easily monitored throughout the case. The pump is then primed, and the fluid collected in a basin that will be used to wet the towel and wash the shoulder and arm at the conclusion of the case. After completing the setup, positioning, prepping, and draping in this fashion, the procedure is now safely ready to begin.